I'm just going to share my screen. I hope everyone can see that okay. Can you see the share screen? Okay, fabulous, lovely. And I will just stop my video to get better streaming. So good morning. Thank you very much to the Keratoconus group and David Gable in particular for the invitation to speak this morning. Given that this is the first virtual AGM by the Keratoconus group, David has very kindly given me a bit of a free rein as to what I can talk about today. Bearing in mind that you've previously heard the excellent speakers Vijay Anand and Dan Gore talk about their respective areas of interest, I thought I would just do a brief overview of keratoconus, touching on its history, the current treatments available at different stages of severity of the condition, and then to arrive at my specialist area of interest and really the end point of keratoconus management, which is corneal transplantation. So keratoconus is derived from the Greek word kerato, meaning horn, and conus, meaning cone, and is one of the corneal ectasias, the cornea being that clear, colorless window over the front of the eye. These corneal ectasias are a group of conditions of variable cause that lead to progressive steepening or bulging, in other words, ectasia of this cornea. And this is associated with a deterioration of vision. It has an incidence of about 1 in 2,000 and affects all populations of the world without prejudice, although it is more common in certain groups, such as those with severe allergies and Down syndrome patients. So a picture of what a normal cornea looks like, this clear colorless window in which, incidentally, a window is reflected at the moment. And then the difference between a keratoconic cornea and a normal cornea in terms of shape. And then to show that more diagrammatically here. So throughout history, keratoconus has been referred by a variety of names as people try to describe the medical condition. And I just put up here some of the more interesting ones. It's been known as ochlodes, which just translates as annoying, sugarloaf cornea, prolapsus corneae, and Kiel-Forger's Hornhaut staphyloma. You can trust the Germans to give you the long name. But it was John Nottingham in his 270-page treatise of 1854 who's widely been credited with the first accurate description of keratoconus. Nottingham's work delved deeply into keratoconus with coverage very reminiscent of a modern review, although in a far less succinct manner. He described the epidemiology, the clinical presentation, the underlying cause and treatment of keratoconus. But unfortunately, the concepts he put forth were very limited because of his lack of our modern understanding of the anatomy and physiology of the eye. And his observations were limited because of his technological limitations at the time. It's interesting, however, that he postulated a similar treatment algorithm to what we use today, and he suggested that optical devices were the management option of choice in the mild stages, with surgery being a last resort. You'll be pleased to hear that none of the surgical methods that he discussed are used in the modern era, but he does make reference to the possible efficacy of corneal transplantation. And just remember that Nottingham wrote this treatise around 160 years ago. So the natural history of keratoconus often detected in late childhood, early adulthood. And I think this really increases the importance of yearly eye checks in children and as early adults, because there's nothing more heartbreaking than when a young adult presents to the optician and they pick up advanced keratoconus and he reports back to me in clinic, well, it's because it was the first time I went to the optician. The cause of keratoconus is unknown, but it's believed to occur due to a combination of genetic, environmental, and possibly hormonal factors. Although 7% of those affected do have a family history of the condition, there isn't one particular gene that has been identified. There are possibly several that work in conjunction with each other. It tends to progress as a condition until your early 30s, where a process called natural cross-linking occurs, where the cornea naturally becomes stiffer, and as it becomes stiffer, that bulge that occurs on the front of the cornea just doesn't progress any further. And our responsibility in clinics in the NHS is to look at patients with keratoconus and really monitor them for progression. and decide when is the best time to intervene with treatment. A little brief overview of keratoconus treatment. I did have to scour the internet to find an algorithm in line with my own management strategy, and this probably fits the bill. Important to say here that the management is very different in children and adults. And as I said, the aim is to monitor for progression so you can maximize or maintain a good level of vision. So what are the tiers of treatment for keratoconus? For patients whose vision can be adequately corrected with spectacles, then really no other treatment is necessary other than monitoring to make sure the treatment doesn't get worse. I do always advise my patients that they mustn't rub their eyes. And some say to me, well, how can I stop myself? And the answer to that is by the use of lubricants. Artificial teardrops, lubricants are harmless. And I say to my patients, every time you want to touch that hand to your eye, instead reach for that lubricant bottle and put a drop into your eye. It's very important in these patients to control your allergies. So often keratoconus can be found in patients who have hay fever, rhinitis, asthma, eczema, and it's very important to get on top of their allergies, especially their ocular allergies. What limits the use of spectacles in keratoconus patients is astigmatism, more specifically irregular astigmatism. And I will illustrate this point shortly because often the word astigmatism is thrown about, but it's not really, nobody really describes what astigmatism is and what it is about the astigmatism found in keratoconus that makes it so particularly difficult to treat. Once contact lenses fail or they're not tolerated, then we progress to the various surgical options. And at all of these stages, we look for progression, to treat progression where possible, to stabilize the shape and prevent the need for a higher tier of treatment. So what is astigmatism? A normal human eyeball is shaped like a football and quite regular. So the curvature in one plane, illustrated by the red line here, is very similar to the curvature in a plane perpendicular. Some people have squashed eyeballs in that they tend to be wider in one meridian, and at 90 degrees to this meridian, they're shorter. So they're shaped more like a rugby ball. And again, this too is entirely normal. It's very rare that you have someone who has a perfectly shaped spherical eye. And both of these are known as regular astigmatism because the axes of the axes illustrated are at 90 degrees to each other. What is unusual in keratoconus is there's something called irregular astigmatism. The eyeball is not regular. It tends to be more squashed at one end, so more bulging towards one side than it is at the other. And therefore, it makes these axes that you have not at 90 degrees to each other. And this is called irregular astigmatism. And this is what makes clear vision with spectacles very difficult to achieve. And that's why we have to resort to contact lenses. So these can be the rigid small gas purple mode contact lenses. People find these quite difficult to tolerate, so you may have to pair them up with a soft contact lens just to increase the tolerance of these hard pieces of plastic in front of the eye. And then you have the different forms of scleral contact lenses that you can use, the large diameter ones or the mini scleral lenses. Now, other options, I'm not going to mention cross-linking in any detail since I know Dan Gore has spoken to you about this, but I do want to mention other surgical options before coming to the holy grail of visual rehabilitation, which is transplant surgery. So there was something called thermokeratoplasty, but this has now been abandoned, but in case the word comes up, it was just where these heat spots are applied to the flatter meridian of the cornea to try to make them more steeper, but that had many problems, so it's really been abandoned. You can have intrastromal corneal inserts, which are little pieces of plastic, and I'm going to spend a little bit of time talking to you about these. There are certain refractive laser procedures that can be done. So refractive laser surgery, that surgery that everyone is keen to have if they're short-sighted to help improve their vision so they're not reliant on glasses or contact lenses, that can be used for patients with keratoconus in the very mild stages. And then you can have combined procedures. So you can use refractive laser to improve the shape of the front of the eye, and then you can cross-link it to really stabilize that shape and prevent progression in the hope of achieving better vision for the patient. And then finally, keratoplasty, the medical term for corneal transplantation. And lamellar or penetrating refers to the different types, which I'll expand on in due course. So intrastromal ring segments, these are small devices that are made of polymethyl methacrylate, so acrylic, a plastic. And they are implanted in the corneal stroma to induce a change in the shape of the cornea and therefore the refractive power of this tissue. Essentially, they work by flattening the cornea that is too steep and making the patient more contact lens tolerant. There are several devices on the market. One device is an open-ended plastic ring, which is inserted into a channel that's created with specially designed instruments. That's known as a Kera ring. And the thickness of the ring determines how much of a change occurs in the shape of the cornea. Sometimes you can use segments of the ring, so you can use Intacs or Ferrara segments in order to induce this change. But it's very important to have stability of the disease before use, or at least if you put this device in when potentially the disease can still be progressing, then to cross-link afterwards in order to stabilize the shape. However, even with these inserts in, you may still need contact lenses or glasses, but you'll have a flatter cornea in theory, so the fit should be easier. Advantages of these use, it's a minimally invasive outpatient procedure with very low morbidity. The surgery is completed in the peripheral retina, so the central part of the retina, that part that's responsible for your vision, is not disturbed. The results are quite rapid and they're predictable. There is a reduced risk of visual adverse effects, and it produces a long-term convenient refractive correction. These devices are removable, so in case that you have problems with them, they can easily be removed and they don't prevent you from going on to have corneal transplant surgery. Important to say that there's no removal of corneal tissue. You don't even penetrate into the eye with these devices. That all the surgeries occurs on the corneal surface or in the corneal tissue itself. But it sounds wonderful. However, there are disadvantages. The technology is still quite new, and there are some emergent complications. Sometimes patients complain of a diurnal fluctuation in their vision. Sometimes that corneal tissue can become opacified. I certainly know of one patient where these segments have migrated into the eye and caused a variety of problems. So they sound great, but they are it's quite a difficult operation, and it does have its own challenges. So indications, often it's best where you have unilateral keratoconus, a patient who is intolerant to contact lens wear and wants to avoid a transplant. So, you know, it can be mild keratoconus, it can be moderate keratoconus, but it's too early for you to get to that end stage of trying to replace the cornea entirely. It's very important that the cornea mustn't be too steep, because you just won't be able to produce adequate flattening. The vision shouldn't be too bad, so no worse than 6/18. And again, the keratoconus can't be too advanced, because you need a certain thickness of the corneal tissue in order for you to be able to insert these implants in adequately. So that should be around 400 microns, so 0.4 of a millimeter at the site of insertion. Patients should be more than 21 years old, and they should have realistic expectations. This is not to improve your vision to 6/6. This is just to improve your vision from what it is, or to stabilize it and stop it from getting worse. And it goes without saying that you can't have any central corneal scarring, because that sort of defeats the purpose of what you're doing. Exclusion criteria, as listed here, a cornea that's too steep, or a patient has really high expectations, because as a doctor, I just can't manage those expectations. Patients who have any form of ocular surface disease, a very severe dry eyes, any form of immune disease that affects the surface of the eye, patients whose corneas are too thin because their disease is too advanced. I wouldn't suggest this procedure on any patient who has a very good level of vision with contact lenses, because contact lenses are obviously working. Certain systemic diseases such as diabetes can affect wound healing. So again, I wouldn't recommend this procedure in those patients. And if you have any form of herpes infection of the eye, so either herpes simplex, the cold sore infection of the eye, or you've previously had shingles of the eye, then I wouldn't recommend this procedure. Complications, as I said, you can have problems with wound healing. The stroma can become affected and can become scarred and hazy. You can get various forms of inflammation on the front of the eye. As I alluded to earlier, you can have migration of these segments of plastic rings, so they can migrate away from where you wanted them to be, or they can actually migrate into the eye. And obviously with any form of surgery, there's the risks of infection and ongoing inflammation. So to show you what these look like, so this is the intacs. These are segments of plastic inserted into the eye, and essentially that's what they look like inside the eye. Or you can have one whole ring of plastic known as a Kero ring, and again, this is what it looks like. Please note it doesn't affect the central part of the cornea, and there's no scarring here over the central visual axis. I just wanted to show you a visual representation, because I never quite understood how these devices worked until I saw this slide. And here you have a patient standing underneath, a person standing underneath a tent. And if they stretch out their arms, as they push the sides of the tent out, then the top of the tent comes down. So that's really the effect that you're achieving in a keratoconic cornea. You're pushing out the sides of the cornea, therefore flattening the central part, making the central part less steep. So the next form of intervention is laser refractive procedures. There is a particular protocol known as the Athens protocol, which, as the name implies, was developed in Athens by John Kanellopoulos and his team. And essentially, this involves laser refractive intervention, so laser surgery on the front of the eye to alter the shape of the front of the eye. And once you've altered the shape, made the shape better, you then go ahead and cross-link, so you maintain that shape. Important to note here that it's really important to combine these procedures, because keratoconus per se is actually a contraindication to any form of laser refractive surgery to correct your vision. So if you go, if you are very highly myopic and you go to one of these laser refractive centers, one of the tests they do is a mapping of the front of your eye. And if there's any hint that you have keratoconus, then they really should not be operating on you at all. However, laser refractive surgery in a keratoconic patient combined with corneal collagen cross-linking is certainly one way of improving the vision. So what is the Athens protocol? So essentially it involves one form of laser where they scrape the front layer of cells of the eye. Then they use a different kind of laser to shape the surface of the eye, make that shape better, often by trying to steepen the flat areas of the cornea. Then they apply then they apply something called mitomycin C, which is a substance that tries to prevent scarring from occurring after all this laser that you've had done, which can precipitate scarring. And then finally, they do some corneal collagen cross-linking to really freeze the shape of the cornea. So all I want to say here is that who would this procedure be suitable for? Well, it's often these patients down in the corner here. This is the keratoconic patient who does not have any scarring of their cornea, who can get good vision with their contact lenses, but who has evidence of progression and their contact lens intolerance. So those are the best patients in whom this Athens protocol would work best in. And so we arrive at the final surgical option, which is transplantation. There is Corneal transplantation is the most common of all the organ transplants performed in the world. And when I scoured the literature, there was only one report I can find from 2016 that undertook a global survey of corneal transplantation and eye banking. In 2012, they found that there were about 100 and just under 200,000 corneal transplants performed in 116 countries, and this covered 95% of the world's population. And these were procured from just under 300,000 corneas that had been donated and stored in roughly 750 eye banks around the world. It is estimated that about 12.7 million people are waiting for corneal transplants around the world, and this supply is only meeting 1 in 70 of the patient demands for transplant surgery. In the UK, we do around 4,000 transplants per year in about 150 centres, but in order to do that, we need about 4,500 corneas. What are the major indications? These include optical, to improve the vision, such as that in patients with keratoconus or scarring from infection. Therapeutic, where you have pain, infection, and you need to take that disease out of the eye. Tectonic, where you've had an injury to the cornea and you just can't close the cornea up, so you have to replace the cornea to maintain the safety of the eye. And I'm sad to say that there are parts of the world that even do this for cosmetics reasons, so that patients got very, very bad appearance to the front of the eye and they want to improve the appearance. But transplantation should really be the last resort. It should only be undertaken after adequate trial of other less invasive therapies that have been undertaken. A little bit of history about corneal transplantation. I have a great interest in medical history because I think only by understanding medical history you really appreciate where we are and what we are able to do today. So in 1905, Edward Zerm encountered a patient called Alois Glogar in Prague in the old Czechoslovakia. Alois Glogar was a 45-year-old day farm labourer from a small town whose corneas in both eyes had turned white and opaque a year earlier because he'd been working with lime scale as he was cleaning out chicken coop. Now, around the same time as he was treating Glogar, this 11-year-old boy called Karl Brauer was brought into Zerm's clinic, and this young child had a penetrating injury with iron metal foreign bodies irretrievably lodged in his eyes, but luckily sparing the cornea. Although Zerm attempted to save the eyes of this young child, in the end he gave up, and with the father's permission enucleated one of the eyes and saved the corneas for transplantation into Glogar's. He took one cornea and he fashioned two 5mm grafts from this and transplanted them into Glogar's eyes. And although complications affected one eye, the other remained clear, allowing Glogar to return to work after about 6 months. This was 120 years ago. This was at a time when none of the current medical technologies existed. So it really does put into perspective the achievement the Zerm was the achievement the Zerm had at that time. André Magiteau is the first one to demonstrate the viability of the cornea after death, and he was a pioneer in the application of this knowledge to the practice of corneal scarring. Anton Elschig is best known for performing corneal transplants in the early days of keratoplasty, and he was credited with developing a method using a piece of instrumentation introduced by Eugen von Hippel, the trephine, which really helped in the method of corneal transplantation. Vladimir Filatov successfully granted a patient using corneal tissue from a deceased person. He was the first person to say that perhaps we can use corneas from people who have died, so they don't need to be alive for us to be able to retrieve the cornea. And then finally, there is Ramon Castroviejo. He improved the technique of the operation in the 1930s and the 40s in the USA, and prompted worldwide adoption as corneal transplantation as a standard way to deal with severe corneal pathology. And he certainly named a lot of instruments that we still use after himself. And here we are in the modern era where we have improvements in the retrieval, storage, and testing of corneal tissue, improvements in instrumentation and suture materials. And again, to put this into context, we use suture materials that are finer than the human hair. If you take this suture and wave it around in the air, you can't actually see it. That's why we use operating microscopes. We've had huge advances in microscope technology, and we have at our disposal a variety of antibiotics and anti-rejection drugs, all delivered topically. So, and our techniques have evolved such that we are now able to not just only transplant a whole cornea, but layers of the cornea. And again, to put this into context, a normal cornea has a thickness of 0.5 millimeter. That keratoconic cornea can be 0.3, 0.4 of a millimeter at its most central point. And we have developed skills that enable us to cut layers in this fine cornea to transplant layers of the cornea. So, you know, once you understand the history, it really makes you appreciate where we are today and what we are able to achieve today. A little bit about corneal transplantation. Corneas are the least donated part of the body. Only 1 in 10 people on the National Organ Donor Register have agreed to have their corneas donated. And I'm going to do a little bit of self-promotion here. I hope you don't mind. But recently for the NHS Blood and Tissue Bank, I did a YouTube video to ask for people to donate their corneas. So if you ever have time, please check this video out, and more importantly, share it with your friends and family, just to get the word out that we need more corneas. The sooner that a donation takes place from a donor, the better the transplant outcome, but corneas can be donated after 24 hours after you die. And again, some myths: it's not the whole eye that's transplanted, it's just this clear window at the front of the eye, although we can use other parts. The sclera, which is the white part of the eye, can also be used. If you do donate your corneas, it does not affect how you look, and a lot of patients who have donated the corneas have open casket funerals, and certainly the people who retrieve the eyes take great care and effort to give the deceased a very natural appearance. Cancer doesn't stop you donating your eyes, nor does poor eyesight. A lot of the conditions that give people poor eyesight are right at the back of the eye, which doesn't affect the functioning of the corneas. And really, there is no limit to age. Anyone can donate their corneas. Transplanted tissues, these corneas have to be procured, tested, preserved, stored, and distributed by eye banks that are inspected and licensed by the Human Tissue Authority. And just another point of note: when a corneal tissue is donated, it's usually used within 28 days. And there is an informal arrangement in place for age matching. So we try to match a donor with a recipient in terms of age, not necessarily in terms of sex. So often you may have a male donor given to a female recipient, or vice versa. But there is a informal understanding that you can also, as an 80-year-old, receive the corneas from a 50-year-old, because there is a 30-year age discrepancy that is acceptable. And in the same way, a 20-year-old who needs a cornea may receive the corneal tissue from a 50 or a 40 or a 50-year-old. So just something to bear in mind. A little bit of basic anatomy, so I'm sorry, I just want to go through very quickly, just so I can make my points about partial corneal transplantation more understandable. The cornea has 5 layers, so very briefly: epithelium, Bowman's layer, stroma, descemes, and endothelium. And just to show you that more clearly, I've just put this picture up, and really I just want you to understand that there are 3 layers in front and 2 layers at the back: descemes and endothelium at the back, and these three layers in the front. And these are the layers that we typically transplant when we do partial thickness corneal transplantation. So the types of corneal transplant: you can have a penetrating or a full thickness keratoplasty, when a button of all of those 5 layers of the cornea is exchanged. Or you can have a lamella, or a layer partial thickness keratoplasty, when layers of the cornea are changed. If you take those 3 anterior layers that I just showed you. That's called anterior lamellar keratoplasty, and the deeper you go, the better. So you put the label deep lamellar keratoplasty in front. And if you take the posterior 2 layers, that's known as posterior lamellar keratoplasty, and there are 2 types of that, DSEC and DMEC. So these are sort of getting a bit into medical terminology here, but essentially you have the anterior lamellar keratoplasty and the posterior lamellar keratoplasties. And again, just to show you this in a diagrammatic representation, here you have a full thickness corneal transplant, but a button of the cornea is taken out. Or you can have a layer, the front layer is taken out. This is a deep anterior lamellar keratoplasty where a lot of the front layer is taken out. Or you can have a thinner lamellar keratoplasty where more superficial layers are taken out. And at the back, you can have the posterior lamellar keratoplasties, depending on how much tissue you take out. Penetrating keratoplasty is the standard surgical corneal transplantation technique. There are risks and problems associated with it, including rejection, infection, traumatic rupture. You have a wound, a full thickness wound in the front of your eye, and any form of trauma to that eye can cause this wound to prolapse. So the cornea, that transplanted tissue, can suddenly come off. The time for recovery is quite long after a penetrating keratoplasty, and we have more problems with astigmatism. When I try to explain to my patient what is involved in corneal transplant surgery, I say to them, imagine you've got a block of jelly in front of you, and you're going to take a scoop of that jelly out, and you're going to get another blob of jelly, and you're going to take an equivalent scoop out from the other jelly and put it into your first block. So you can see it's never going to be perfect. It is an art. It is an art to try to match those 2 scoops from the donor to the recipient up. I'm also just going to come back to this issue of traumatic rupture and sort of give you a little story from one of my patients, which really affected me. I had a young lady, she was in her early 30s, who had a condition inside the eye that had affected her corneas, and she'd had corneal transplants in both eyes. The right eye, she'd had multiple rejection episodes and had failed. So essentially, one eye was a completely blind eye, and so she was dependent on her other corneal transplant in her only eye. She had a 2-year-old daughter, and she bought some red shoes for this 2-year-old daughter. And the 2-year-old daughter, in the typical toddler tantrum, didn't like her red shoes. So she picked them up and thrown them at her mother. And the shoes had landed right in the only good eye of this patient, causing that cornea to rupture, and therefore she'd lost her sight. So it just goes to show it doesn't matter how many years after your transplant, you have a fragile eye that you really have to take a great deal of care of. And to show you what a full thickness transplant looks like, so here you have the cornea, you take this button out, you take the transplanted tissue and you sew it in place, to put it mildly. And again, to show you what this looks like, so these are interrupted sutures put into place in order to keep that cornea safe. And after approximately 18 to 2 years, these sutures come out. You can also have continuous sutures, and this is a little bit of continuous suture overkill, where the surgeon has gone round the cornea twice with a long uninterrupted suture. So what are the good and bad points of penetrating keratoplasty? You do have faster visual recovery. Your vision gets better far faster than with a partial thickness transplant. From a surgical point of view, it's much easier to learn and certainly much easier to perform. And your final visual acuity tends to be better. But there is the risk of infection because you've made a hole in the front of the eye in order to remove the tissue and put the transplanted tissue in. And the risks of rejection are higher because you are transplanting more tissue. There is a longer use of post-operative drops, and the stitches remain in place for far longer. And as I have explained, there is this ongoing long-term fragility of the globe. The anterior lamellar keratoplasty, which is the other procedure removing the front 3 layers of the cornea that we would consider in patients with keratoconus. This involves replacement of the central anterior cornea, and you leave that back layer, the endothelium, intact. And in theory, by leaving that back layer intact, you reduce your chances of rejection. So advantages are the risk of rejection. I've written eliminated here in quotation marks because that's what I was taught when I did my corneal fellowship, but experience has taught me it's not eliminated, it's just reduced because you have transplanted less tissue. There is this theory that because you've only taken the anterior layer out, you have increased structural integrity and less fragility of the globe. I personally disagree with that because of the amount of tissue that you leave behind is so thin that I think that in terms of structural fragility, it's very, very similar to what you would experience in a full thickness transplant. However, you do have faster visual rehabilitation and you do have less problems with post-op astigmatism. But the disadvantages are it's surgically far more challenging. As I explained earlier, you've got to essentially hand dissect a layer across a piece of tissue that's only 3 or 4/10 of a millimeter thick. And the visual acuity, the final visual acuity achieved is not quite as good as a penetrating keratoplasty because you have an interface. You have your donor tissue placed on top of a bed of your own tissue. So there is an interface in place there. So just to show you this diagrammatically again, you have this area of these 2/3 of the front of the eye, this layer removed and replaced by donor tissue in its place and stitched into position. So why one or the other? Ultimately, the decision is based on whether you have corneal scarring or not. If you have any form of corneal scarring, you just can't do a lamellar graft. You have to do a full thickness graft. But if you don't have scarring, then the choice actually comes down to the patient. It's not for me to make that decision. I offer the pros and cons of each technique and then leave it to the patient to decide. So what are the advantages for having a partial thickness transplant? Well, there are fewer problems with rejection, potentially increased wound strength, and the corneal sutures are removed far faster, meaning that you achieve visual rehabilitation faster. But the disadvantages include the fact that your visual acuity is not quite as good at the end stage after rehab as it would be with a full thickness transplant. From my point of view, it's technically more challenging, and sometimes we start off with all good intentions to do a lamella, a partial thickness graft, but we just can't get that layer. We end up going into the eye and therefore having to convert to a full thickness transplant. And that occurs in about 1 in 8 of all patients. So really important when you consent a patient who wants to have a partial thickness transplant that you inform them that there is a chance, a 12.5% chance that you may end up having a full thickness because it was too technically challenging for me as a surgeon to be able to dissect that layer. Post-operatively, we follow patients up to complete visual rehabilitation. Most patients will require some form of vision correction afterwards, whether that be spectacles or contact lenses. We have to ensure the wound is completely healed in order to time when it's most appropriate to take those sutures out. And as I said, sutures often come out somewhere between 12 to 24 months, depending on what type of graft you have. It doesn't mean that if you have sutures in place, you can't get good vision. Certain surgeons feel that all sutures should come out. I personally am quite happy to get a patient fitted with contact lenses or glasses with their stitches in place. And then you also need to have routine eye care. There are lots of issues that can arise with patients who've had transplant surgery, including glaucoma. And so you need to be followed up to check for other eye problems in addition to how your graft is faring. And there is a lifelong risk, irrespective of the type of surgery, of graft rejection. Sometimes I've had patients who've come in to me after having had a graft 20 years previously with their first episode of rejection, and they said to me, you know, this can't be, I didn't think it was rejection. That's why I didn't bother coming in earlier, because it's been 20 years. It really doesn't matter how many years you've had your graft. In the end, it is tissue from another individual that has been introduced into your body, and there is a potential that at some stage your body may recognize that this tissue doesn't come from its own self. So when you come to consent patients, I always say to patients, the graft survival rates are very similar between a full thickness and a partial thickness graft. So you have about a 90% survival of 1 year, and this goes down to about 62% for a full thickness graft at 9 years, and around 80% at 8 years for a partial thickness graft. What can affect the survival of a graft? Donors, it really doesn't matter. It has been determined that an age between 11 and 80 has no effect, nor does how long the donor has been stored. However, we do know this graft survival is reduced in children below the age of 10 years and in those elderly patients over the age of 85. Vascularization means that the body produces an abnormal blood vessel reaction to a corneal graft. Now, the cornea is often an avascular tissue. It doesn't have any blood vessels that you can see, but surgery can induce these blood vessels to arise. And if you have repeat surgery and you have your corneal bed being vascularized, that can affect graft survival. Why? Because these blood vessels carry cells that are able to recognize foreign tissue inside the human body. And if an eye becomes inflamed, whether it's inflamed as a result of sort of rejection or infection or any other cause of inflammation, it can affect graft survival. If you've had one graft that's failed, then the risks of survival are reduced, so that by the time you're down to your fourth graft, there's only a 21% survival of 5 years. And we know that there is a possibility of developing a condition called glaucoma in anyone who has a corneal transplant. Glaucoma is where there are effects on the pressures within the eye, and this can cause damage to the nerve at the back of the eye. And someone who never has any problems with glaucoma, they have a good survival of their graft at 80 years. But if they have either previously raised problems with pressure control, or it becomes raised at the time of surgery onwards, then that certainly affects the survival of the graft. Other issues that can affect survival: if you have a severe bacterial infection, that can halve the survival of the graft. If you get any abnormalities in the anatomy of the eye associated with the surgery, that can reduce the survival. We've talked about vascularization, we've talked about glaucoma. Rejection episodes certainly reduce survival of grafts. Because this is certainly for full thickness grafts, this is surgery where you make a hole in the front of the eye. This can affect how well the film, the retina, the back of the eye works. And again, if you get problems with the retina, that can affect the survival of the graft. And endophthalmitis is the most feared of all complications. It is an infection of the eye that is acquired at the time of surgery, and it is a very severe sight-threatening infection, and again that can affect the survival. So what are my responsibilities as a surgeon to you, the patient who wants to undergo corneal transplantation? I think it's very important that we have a good discussion about your visual outcomes and your expectations, and make sure that these outcomes and expectations are realistic. I can't stress this second point enough, especially amongst my young patients who've had the word transplant thrown at them for years and years. They often think that they have a transplant, they wake up from the surgery, and hey ho, their vision is restored. That's not the case. Undertaking a transplant is the beginning of a new long journey that may be complicated along the way. So it requires commitment. It's very important for me as a surgeon to use lay language so I can really make my patient understand. As medics, we are very bad at forgetting not everyone understands the various medical words that we use. And again, I really feel transplant surgery is the last means of visual rehab. Again, to come back to a patient's story, about 2 years ago, I had a patient who attended my clinic, and it was just by chance. His GP has double booked him into a clinic at my hospital and a clinic at a leading teaching hospital not far removed from where I work. He'd been to the leading teaching hospital. He was only 18, and the surgeon there, the consultant surgeon there, has said to him, well, you know, you've got really bad keratoconus. We've cross-linked you. Your vision's not very good. We can offer you lenses, but why bother? Because you're going to need a transplant anyway. And then, so he had this in his mind that at the age of 18, he was going to go ahead and have a transplant. He then came to my clinic and I said to him, well, why don't we just try contact lenses first? Because you're only 18, transplants survive for probably 25 to 30 years, which means by the time you're 48, you're going to need a second transplant. By the time you're 78, you're going to need a third transplant. Let's see if we can buy ourselves time so that your first transplant is perhaps not at the age of 18, but the age of 28. So I referred him to a contact lens clinic that I'm very privileged to have Ken Pullum leading, and Ken fitted him scleral lenses, and he had a dramatic improvement in his vision, and he was very, very pleased. So we bought ourselves time and, you know, lived by the ethos that surgery is the last resort. And really important again that when you discuss surgery, you give patients time to absorb the information. They can go and consult Dr. Google if they want, but I always send patients away for at least a month and then ask them to come back and we make a decision as to whether to proceed or not. It's really important that the patient understands. The patient has to be motivated. They have to want to be, they want to and be able to come for long-term follow-up. They've got to understand that it's going to take time for visual rehabilitation. And as I said earlier, they're not going to wake up from surgery with excellent vision. There are certain limitations to the technique for graft clarity, vision, and the ability to use both eyes together. And again, I've already sort of alluded to this earlier in the talk. And it's also important to say to these patients that they are going to be on long-term drops. Certain surgeons may stop drops on their patients. I don't. I tend to keep my patient on eventually one drop of an immunosuppressant in the form of steroid drops for life. So what are the questions that I get frequently asked? The patient says to me, well, when will I see? You may have some degree of useful vision in possibly hours, days, or weeks, but it can take up to 3 to 20 months for you to achieve any useful vision that will enable you to read properly or drive properly. And contact lenses are going to be needed in approximately 15% of patients because of the astigmatism, because of the challenges of fitting that scoop of jelly from one block into the defect in a second block. How long will the graft survive? Well, keratoconics have a great survival rate. It can be up to 90% at 25 years. With other conditions that affect the cornea, that survival is far less. And how often will they have to come to see me? Well, they would require on average about 12 visits per year. 12 visits over a 2-year period, probably a minimum of 8, but that number can increase if there are any potential complications. Again, considerations, the rehab after the surgery is long and the patient has to be fully aware of that. This is a slow healing process because there are no blood vessels at the cornea. The cornea heals by secondary intention. So it is something that it's not like the skin where you are almost back to normal because of the blood supply, etc. Within 2 to 3 weeks. The healing process can be up to 18 months, 2 years. And the older you are, the longer the healing process takes. What factors affect visual outcome are not always able to be determined beforehand. Patients often feel, especially if they have one eye transplanted, that they've only derived a benefit if that transplanted eye can achieve a vision that is as good as or better than the other eye. And that is a challenge for us as surgeons. Risk factors for failure, we've kind of touched on some of these: glaucoma, a young patient age, increased number of grafts previously, how much vascularization they have of the corneal bed. And there are some people who say some blood groups are less compatible with success of corneal transplantation, but we don't regularly check people for blood groups. Post-op management: once you've had a graft, you are on steroid drops intensively for at least 8 months to 2 years. Sutures are removed anywhere between 8 months to 2 years. Patients often need some form of correction, whether that be a contact lens or a spectacle, in about a third. And as I said, I'm very happy for my patients to have stitches in place and still fit them with a contact lens, as long as the central part of the cornea is clear and the sutures are epithelialized and the wound margins are stable. And as I said previously, there is always a risk of rejection. What is rejection? Rejection is the body recognizing this tissue doesn't belong to you. And I have this little acronym that I always give to my patients: RSVP, R standing for redness, S sensitivity to light, V vision, any change of vision, whether it becomes hazy or blurred or is just not as good as usual, and P if the eye becomes painful. And I always say to my patients, as soon as you get any of these symptoms, you must present yourself to an eye casualty department. It doesn't matter if it's not rejection. I would rather see you and treat that rejection with early intervention rather than for you to say, oh, it's nothing, leave it, and then end up with losing your graft. And so I think that brings me really to the end of my talk. Thank you very much again for the invitation. And I'd be happy to take any questions if there are any questions.
Well, thank you very much, Bita. Interesting, when you go into the history, I see I'm forever grateful to Professor Buckley there and his blue Gillette razor blade. It's 35 years ago, and with that eye I can still read unaided. It's marvelous. But there's quite a few questions on the chat, Bita. So can you look at the chat and see if there's any questions there that you can answer? Can you see the chats?
Yes, I can. So the first question from Kevin Minier. Is keratoconus more prevalent due to excessive close work and or use of screens or computers? The answer is no. Has keratoconus been linked to wearing hard contact lenses in younger age? No. Keratoconus is the biggest risk factor for keratoconus in terms of what a patient can do is rubbing of the eyes. So we know that rubbing of the eyes can make keratoconus far worse. Is it possible for the body to regenerate corneal tissue? The answer is no. Unfortunately, at the moment, we're not able to regenerate anything in the body. That's why we are so dependent on graft tissue and transplantation. There are certain tissues that can be regenerated, such as skin in the lab. And there are certain groups, especially in Australia, who are working on developing artificial corneas in order to plug this gap of the lack of human corneas, but again, that research is very much in its infancy. How is keratoplasty affected by other eye surgery, cataract operations? If you have a corneal graft as a young age and you go on to develop cataracts in your old age, that doesn't stop you from having cataract surgery, but it does put your graft at an increased risk of failure because any surgery that goes into and out of the eye can affect the integrity of that corneal tissue. So if you are, for example, in your mid 40s, 50s, 60s, and you come to me and you want a corneal transplant, and I see that you already have the early stages of cataract, I may advise you to have what is known as a triple procedure, which is one surgery where we do both the cataract operation and the corneal graft in one go. So you can have both of those done if you are in the right age group and there is evidence of the formation of cataracts there. As a transplantee myself, can corneal transplant be a future transplant? That's a good question. And I think the answer at the moment is no. Although, if you think about how long a cornea, a typical person who dies and donates their cornea is 80 years old. If that 80-year-old cornea is then transplanted into a 50-year-old who then lives until they're 90 with that same tissue, that cornea has lasted 120 years, as long as it's still functioning at 90. So at the moment, we don't reuse transplanted tissue. Can that be a possibility in the future? Watch this space. I don't know is the answer. Could I have Ken Pullum's details, please? I think, David, that's...
They've been given. If anyone wants any information, they can always ring the helpline. Any information, any follow-up on any of these topics. I'm sure Anne will only be too pleased to hear from you on the helpline, and certainly give you details of Ken Pullum's, although we're given his address, but we can give you the telephone number of his surgery. Yeah, sorry, carry on, Bita.
Yeah. Amy Marsh has asked, is there any procedure that can improve vision in glasses for those with mild keratoconus? For instance, reducing the impact of double vision and halos privately or on the NHS. And I think, Amy, it really goes back to the middle part of my talk where I was discussing laser refractive surgery, corneal collagen cross-linking, and Intacs. We know in patients who have mild keratoconus, I mean, what we do in the NHS is very much limited by what guidelines we're given. So NICE guidelines state that we can only offer corneal collagen cross-linking to a keratoconic patient if we have evidence of progression. And that progression has to be of a certain value before we can offer it on the NHS. My own personal thinking is that if I had keratoconus, I would get myself cross-linked as soon as possible.
Sorry, just sorry, if you can you hear me okay? Sorry, I should have mentioned I have had cross-linking, and I'm actually, this question is on behalf of myself and someone else that's unable to attend the call today, and we suffer really badly with halos and double vision. Obviously, it is a bit better with glasses. For me, it's not from the other person I'm speaking on behalf of. She has it a lot worse than me. And for me, it's worse with contact lenses. I'm able to wear soft contact lenses, and I've got them in now, but I can't wear them for long, and I can't wear them when I'm like driving or anything like that. So yeah, I have had cross-linking.
Yeah, so I mean, the options there for you would be, we need to try to improve your current shape, and perhaps laser refractive surgery or some form of intact procedure may be able to improve your symptoms. But Amy, I really suggest that if you want to go down those routes, you have to go and see not any laser refractive surgeons, and not your Optimax and Optimed, all of these. You need to go and see someone who is a corneal surgeon with a specialist interest in keratoconus and who has experience of laser refractive surgery. And I mean, off the top of my head, I can give you some names. For example, Dan Gore. Dan Gore is a huge person in the keratoconic world. He has extensive experience with cross-linking and does laser refractive surgery. So please make sure you see the right people, especially if you go down the private route for that.
Sure, thank you.
Then mrgf@cowie.com has says, during these COVID days, what advice would you give us to tell our consultant during our virtual phone call appointments that we sense our eyes are getting worse and affecting our lives? So one plus thing that COVID did for me is I actually set up virtual clinics for my patients. But a virtual clinic, my understanding of what a virtual clinic seems to be different to what you are experiencing. A virtual clinic to me is when a patient comes in and spends 15 minutes in a hospital and undergoes all their tests that are relevant to assessing their keratoconus and then goes home. And I then get access to these tests. I look through them and then I make a decision as to how is the best way to proceed with this patient. Is there evidence of progression or not? I really if you feel your vision is getting worse, you have to let your consultant know that, and then the onus is on the consultant to get you into the hospital to get that topography done, that key test, which is topography, and perhaps a refraction to see if your vision is getting worse. So really, when we talk about virtual clinics, I dislike this idea that a consultant just phones you and says, "Oh, hello, Mrs. Smith, how are your eyes? How's your keratoconus?" You can't make that judgment all the time. You have to have tests that back up what the patient says, and those tests are used to monitor that patient. So a real virtual clinic is where either in a hospital setting or in a community, you go and get your tests done, and then the consultant can remotely look at these tests, phone you up and advise you. So coming back to your question, if you feel your vision is getting worse and none of these tests have been done, you should be a little bit more insistent that your consultant surgeon should get you into the appropriate environment and get topography and refraction done on you. Are most procedures performed under local anesthetic? Corneal collagen cross-linking can be performed under local anesthetic. With all due respect to all the male members on this talk, my experience has been that men are not as good as tolerating any form of surgical intervention as females are. And so I think it's great to offer a corneal collagen cross-linking under local, but I have a little rule that any man under 50, I tend to suggest that they have it done under a general, because they're just not very tolerant of keeping their eyes still, having drapes put on their eyes. The technique I use for collagen cross-linking involves 10 minutes of irradiation with a ultraviolet light, and in that 10 minutes you require that eye to stay still so that ultraviolet light is delivered to the correct place. And if a patient feels that they're just not going to be able to do that, then it would be advisable that it's done under a general. It's not the best way because general has its own risks, but you really have to cater it for the patient. But certainly encourage local anesthetic where you can, and a certain subset of patients may need a general. Corneal collagen intacts, I actually don't do intacts, and the few cases that I've assisted on, the patient has been under a general. Although it is possible to do it under local, because it depends how you create these channels for these plastic inserts to go into. Some people do these manually and it's quite a traumatic procedure, so I would suggest a general anesthetic. Other people who have access to lasers can create these channels via laser, and under those circumstances it is possible to have the operation done under a local anesthetic. When it comes to grafting, I think for the sake of the patient and for my own sake, I would prefer the operation under a general. If you've had cross-linking, can pregnancy trigger the progression of keratoconus again? That's interesting, Amy. Potentially the answer is yes. I think there have been some studies that have said, because of the hormonal effects of pregnancy, that it can cause progression, even if you've had cross-linking. But the problem is, I think the number of patients in any study is so small that probably big studies to assess this have not been performed. I certainly don't recommend having cross-linking if you are keratoconic and pregnant, and I would do it afterwards, just because you don't know how the pregnancy state is going to affect the cornea. Shelley's iPad, if you have scarring, can this be removed to enable corneal transplant? Yes, certainly. If you have scarring, it depends how deep the scarring is. If the scarring is quite superficial, you can still have a corneal transplant, and you can even have a partial thickness corneal transplant. If the scarring is full thickness, then you can have a transplant, but it would be a full thickness transplant. Scarring is really only not indicated for patients who want to have intacts, because it defeats the purpose of the intacts. If you improve the shape, but you still have a cloudy or a misty window, then you're not going to get much benefit from having those intacts put in. Okay, I'm assuming from Claire, can anyone advise corneal collagen cross-linking? I'm assuming by that question you mean epi-on and epi-off. There are two schools of thought. It depends who you ask. Some people say epi-on is better than epi-off. Some people say epi-off is better than epi-on. I have to be honest, Claire, and say it depends which surgeon you speak with, and that in itself is a topic of a talk by itself, because there are lots of schools of thought. There is a lot of new technology coming out. There are problems with epi-off. There are problems with epi-on. So if you don't mind, I'm not going to spend much time answering that question because it is a big question to answer. Can you say a couple of words about pellucid marginal degeneration, I'm assuming? So PMD, pellucid marginal degeneration, is a form of corneal ectasia. It affects the periphery of the cornea as opposed to the central part of the cornea, and affects people who are older in age. Treatment options are actually similar. I have certainly cross-linked patients. I have fitted them with scleral contact lenses. Again, it is a topic that does require its own school of its own presentation. I'm happy to discuss this with you via a chat if you like, Rika, or I can certainly give you some literature that you may want to read that would answer that question. Do progressive new allergies continue to affect the keratoconus over the years, i.e. make the eyes worse? We know that if you have allergy, you are more prone to developing a keratoconus. Could that be because you rub your eyes? Possibly. There's certainly, there's a group of ocular allergy that is very prevalent in Africa called vernal keratoconjunctivitis. This is a allergic eye disease that affects young children. And what has been demonstrated is that this cohort of children have a far higher prevalence of keratoconus when they're an adult, and they feel that there is a very strong association with severe ocular allergy. Whether you develop new allergies or not, I don't think that's relevant. It's the fact that you have an underlying tendency to be an atope, an atopic individual, a patient who is prone to having allergies. So it's very important to get your allergies under control. And again, it's not just allergies in yourself. I think there is a gene or genes that determine allergy. So I often also ask for a family history of allergies. So any history of asthma, eczema, hay fever, rhinitis in any family members. The other point to state here is that it's really important to get your ocular allergy under control, because if you have allergic eye disease, it's one of the risk factors for making grafts fail. Hence, you know, it can precipitate failure of a corneal graft if you have very bad ocular allergy. Is anyone at an upcoming Moorfields eye hospital?
Better make this the last question, I think, Bita. We've worked you really hard.
No problem. Find out. Okay, sorry. I don't think I've had oh, here we go. I am administrator. I have cataracts and had a graft 37 years ago. Will a specialist have to do my surgery? I would highly recommend that it's a corneal surgeon who does your surgery, because we would take certain extra precautions during the surgery to try to protect your graft. If you go to any corneal surgeon, they're not always cognizant of the special procedures and special precautions they have to take to protect that corneal graft. So in short, yes, please do make sure it's a specialist corneal surgeon.
I think we better let Bita go. She's worked really hard. This has been much better than I even hoped for. This has been a really good session. So if you don't mind, I think I'll wind up now and say thanks very much. And Bita, if you send us a link to your video about donation,
I will do. Thank you very much.
Yeah, we'll put that on the